Good morning. So I want to do a little bit of a review for our psych test. We're going to talk a little bit about abuse, and also we're going to talk about addiction. So we'll start with abuse, just some things to keep in mind. One thing we want to think about is children. Any incidents with children that we might think would be abuse, we would want to report that to CPS. It's mandated that we report anything for minors. Okay, now we don't have to prove whether there's something going on, but we have to at least bring it to their attention, and then it's from there, it's CPS's job to investigate that. Okay, some other things we need to think about: elder abuse, domestic violence, rape, all of those things. We are not required to report that unless the party involved or the victim would want us to do that or to help them make that report. Now, in some states it may be different if the elder is deemed incompetent, or if it is an adult child that is deemed incompetent, things like that. Or maybe I shouldn't say child, but maybe somebody they're taking care of that's not quite an elder but is deemed incompetent. That may vary state to state how we would report that. Some other things to think of in cases of rape. Think about the traumatic event that somebody has just been through. If they do come to the hospital and they want to be checked and have the forensic nurse examiner check them over, do the rape kit, things like that, then we would just have to really keep in mind that getting the tests themselves may be traumatic. Remember, that test is going to involve, at minimum, probably a speculum and vaginal swabs and things like that. That could be a little traumatic for them considering what they had just went through. So we want to keep that in mind. We want to just be with the patient, be there for them, leave their judgment at the door, of course, and just acknowledge that it may take them a little while to process those feelings and want to have those tests done to confirm all of those things. Let me think. Anything else about abuse? Of course, there are other things. Some things with child abuse, things to look out for. Obviously, if the injury is not consistent with the history from the caregiver or parents, that may throw up a flag for child abuse. So again, that's something that we would want to report. Now, talking about domestic violence, of course, it is not required that we report that. But if it should turn into a homicide, as we've talked about so many times, unfortunately, these victims end up killed, things like that, that makes it a different story. At that time, remember that we need to utilize our community resources for our patients, our social workers, our crisis centers, crisis counselors, any of the shelters, but we cannot make them do these things, but we do need to let them know that they are available. Okay. Moving on to review addiction and substance abuse. I'm going to spend most of the time with opioid and alcohol, but there are some other things to think of. So, what are our stimulants? Our cocaine, our PCP, amphetamines, anything like that, abusing prescription or straight like Adderall, any of the ADHD drugs that are stimulants, any of those fall into that category of things they can abuse as a stimulant. Okay. With cocaine, big ones are when they can have chest pain because it causes extreme hypertension. So they can have chest pain, of course, hypertension, possibly a headache. The biggest thing is that if they are snorting, that we can see damage to the septum. They can have nosebleeds. They can have inflammation like all through the cartilage here. They could have a lot of problems with that. So we would want to keep that in mind. And like I said, they may have chest pain. They may want to brush it off as, it's no big deal. But it really could be a big deal. And chest pain, hypertension, all of that comes down to perfusion issues, of course, because we could have some ischemia because of that, and that's why they're getting that chest pain as well. Something is not perfusing the way it should because of the cocaine use. Okay. Let's see. So let's talk about opioid use and opioid overdose. So we know opioids suppress the respiratory system. The reversalent for that is Narcan. Okay. I did give you guys a link to do the online training. It doesn't give you a certificate, but you can, I think, call the pharmacy still to tell them that you want to get Narcan if you think you need to carry it on you. However, if you do it that way, you may have to pay for it. I'm not sure. Unfortunately, with this time that we're going through, the health department has suspended all of their trainings anyway. So if we were in class, we still couldn't get them, unfortunately. So she did refer me to that link. Okay. All right. So we want to keep Narcan on hand, in these cases of opioid overdose. So what we may see with overdose of opioids, we may see respiratory arrest or hypopnea, which is low respiratory count, pale or blue skin, okay, possibly non-responsive to stimuli, okay. While they are in our care, our priority is maintaining the vital functions and really the respiratory status. So that may mean Narcan and being close observation in the ICU. That may mean Narcan to the point, if the overdose was bad enough, the intake of the opiate was bad enough, they may need ventilator support. Okay, so other things we're going to do. If they are in ICU or med-surg, wherever they may be, they may start withdrawing from that opiate almost immediately. It just depends on how long they have been abusing opiates, how much they have abused. Did they have a tolerance to it and not realize how much they were actually taking in? And once you cut the body off from that, it will start to, they will start to withdraw. And what it does is it kind of puts their CNS in overdrive, because essentially the neurons are jacked up. And I'm taking this right from that concept sheet that I sent out. It's acute opioid overdose and acute alcohol withdrawal. It's got the concept chart there for all of these things. Okay. You could see seizure activity, things like that with withdrawal. But while they're overdosing, respiratory support, okay, so we need to monitor their SAT, ventilator care, maintain their blood pressure and their heart rate, check their cap refill, all that good stuff. In crisis time, they're probably going to be NPO, okay? IV hydration is needed, possible TPN if needed. Resume their regular diet when the doctor clears or the nurse practitioner clears that patient to have or advances tolerated, anything like that. If they should have vomiting because they're starting to withdraw, or say they were in recovery position, they were vomiting a lot after resuscitation, we may need to monitor electrolytes as well. Okay. We need to explain all of these things to the family, explain care to the patient, as always. Keep them informed of what's going on, even if they are sedated or comatose. Remember, they say that hearing is the last sense to go. We still need to talk to them and make sure they know what is going on. Okay. Now, in critical stages, they may need a Foley while they're in ICU, otherwise routine INO. Okay. We need to also calculate that IV intake as well. With our psychosocial things, we would want to get a crisis counselor, okay, social work referral. We could get a crisis bed for opiate treatment. Once discharged from the ICU area and they're medically stable to go to treatment, they could either go to an inpatient center, they could go to behavioral health for a crisis bed. There are different things that we could choose from the patient or the patient could choose to see, where they want to go. Okay. We also need to teach signs and symptoms of overdose to family. We know that if they overdose once, it is likely that they will do it again. So we need to teach these signs and symptoms to family. Also, the Narconon support group has been proven to be beneficial. Any kind of community support groups, that has been proven to be the best treatment for addiction and recovery. One of the best treatments. Look at AA, NA. It could be any other drug abuse, substance abuse support groups. When they have that sense of community, we know that they're going to be more effective, or it will be more effective. They'll be more compliant kind of thing. Okay. We also want to monitor their vitals closely. If we are treating them for substance withdrawal, let's say they've started methadone or Subutex, typically in the hospital it would be methadone. We want to make sure that they have swallowed their medications. Always stay with the patient to give their medication. Okay. Now, for crisis care, again, all the way here on the end of that worksheet I have here, we'll talk about the Narcan, the ventilator. We've talked about that already. Rescue breathing and recovery position until EMS arrives to decrease the risk of aspiration. So Narcan can be given in multiple doses every 2 minutes. It can be given. Now, the thing with that is, if they have been dependent on opiates for a long time, and I see this in my neonatal population a lot, the more Narcan you give, you're cutting off that opiate, the likelier they are, the higher chance they are of having a seizure. So we have to be very careful with that as we're giving all that Narcan. If we cut off their opiates, they're going to seize. Obviously, though, we have to have them breathe too. So it's like, okay, let's get them breathing, and then we have to closely monitor for seizure activity to make sure that there's not going to be any problems. We want to wear gloves when working with these patients. Now, this is hospital setting, but I'm meaning more in the field, because you don't know, is there substances on their hands, on their clothes? You've heard about the fentanyl leaching through the skin, high doses that are deadly. So as healthcare providers, we want to protect ourselves too. EMS workers, anybody on the front lines with these patients, we want to protect protect ourselves against that as well. Now, again, I always talk about leaving your feelings at the door. You're going to check your baggage at the door. That is because we have to get past our own bias, our own feelings that we have about this, and step up and be that nurse that's going to take care of the patient no matter what. Okay. Another thing, as our patients start to withdraw, because a lot of times they will, we would want to use the CNAW scale. Now, CNAW is looking at and that's CINA. That's looking at withdrawal symptoms, and they're going to be scored based upon what is going on with them. So some things we may see. We may see sweating, irritability, vomiting, diarrhea, hypertension, tachypnea, fever. Does this make sense? Increase in heart rate, and that's because our nervous system is in overdrive. It is all jacked up. It really is. The neurons are super excited, and this is what's happening, and this is why we could have a seizure. It's also why it speeds up the cardiac system, the GI system, so they could have diarrhea, they could vomit, anything like that. It's because the neurons are in hyperdrive, so to speak, or all jacked up. Okay. All right. So moving on to alcohol abuse, acute intoxication and withdrawal. We'll talk about that. Alcohol is the number one abused substance in the United States. So, number one abused substance. Okay. If they have acute intoxication. Okay. Obviously, we would want to probably keep them on their side. We want to hydrate them. They need the thiamine. They might need the banana bag. We need to look at their electrolytes. If they've been abusing alcohol for a long time, we need to look at our liver function panels. We need to look, at coagulation, possibly the whole CMP. Like I said, we need to look at the electrolytes too. Okay. Now, We also would not say they have a headache. Headache is common after a bad night of drinking, right, with a hangover, and they were acutely intoxicated. Now they have a pounding headache. We do not want to give them Tylenol or anything else that might be considered hepatotoxic because, it could affect the liver. So we don't want to do that at that point. So maybe we could use, and also we wouldn't want to give aspirin either until we know the coagulation panel. So maybe we could do probably like a low dose Motrin, something like that is what the provider would want for a headache. You can also give them an ice pack, make sure they're drinking fluids. If they're allowed to have fluids at that point, they can even have a little bit of caffeine that might help with that headache. So we got to keep all of that in mind. Okay. Now, and again, with acute alcohol, like the intoxication, really it's making sure their airway's clear because they vomit. Okay, they don't necessarily need ventilator support. Possibly, not always, but we have to make sure airway is clear. We're keeping them clean because they could be vomiting all over themselves. They could be sweating, things like that. So we want to keep their linens clean, keep their gown, pajamas, whatnot they have clean to avoid skin breakdown and things like that. Also, we want to, like I said, we want to hydrate them, make sure they have their thiamine, their banana bag, all that good stuff. So for acute intoxication, it's basically preventing aspiration, keeping them hydrated. And they might throw up all over the place. Sometimes all it takes is just a little bit of movement and they're thrown up everywhere. So keep yourself safe too with a gown or something when you're working with them so you're not getting stuff all over you. Okay, so now for withdrawal. Another thing with withdrawal for alcohol. The neurons are super excited once again. The biggest risk now is seizure activity. Okay, so we need to prevent that. We need to score them. Okay, now for this scoring, we're going to use the CIWA, C-I-W-A, the CIWA scale. Okay, and I want you to look that one up as well. It's going to grade the patients on certain categories. Anxiety, tremors, vomiting is part of that. They may also be very irritable. Okay. Poor sleep. They may have hypertension. Again, the body's kind of in overdrive. Now, typically you do not see diarrhea with alcohol withdrawal. That's typically mostly your opiates. So you don't usually see it with alcohol withdrawal. More so vomiting with that. Okay. So we want to give them some anxiety meds. We want to keep their linens and their clothing clean, provide hygiene, things like that. If they are vomiting, sweating too, they may see too. Monitor their routine vitals. Usually no respiratory suppression with acute alcohol withdrawal or intoxication. Usually no issue with that. Now, respiratory support if seizure activity. As with all patients that may have a seizure, we have to make sure that we can clear the airway, that we can get them on their side in the recovery position. And we'll talk about meds for seizures here in a minute. Okay. For nutrition, we're looking at the banana bag again, the thiamine, light replacement, and this could be if they come in super intoxicated, okay. As we try to get that out of their system, they could start withdrawing because if it's been 24 hours, 48 hours since they've had something to drink, you are likely going to see these symptoms, okay. So we have to, we're kind of treating it all kind of together, but kind of not kind of thing. Obviously, we would start with the acute needs, which may be preventing aspiration, keeping them hydrated, things like that. And then we're also still doing these things while they start to withdraw. Okay. We want to explain to the patient and the family, explain the care to them, keep them informed, explain the CIWA scale for alcohol withdrawal. We want to talk to them about that if we're going to be doing that with them. They may have a Foley in the ICU, may or may not. Otherwise, routine I&O, okay, we need to look at that IV intake as well. Again, for psychosocial needs, we can refer to the crisis counselor, the social worker. We could get a treatment bed referral if that's what the patient wants to do. As long as they are medically stable, they can go to treatment facilities. And there's much more, I think, treatment facilities for alcohol abuse than perhaps the opioids. Okay. I think there's a lot more. Also, we want them to go to AA. They do better in that community setting. Okay. All right. There's a very high risk of relapse. Okay. We want to educate the patient. AA can be voluntary. It also can be court ordered. It just kind of depends. If they have legal issues such as a DUI or property damage because they wrecked a car, things like that, into somebody's, home or fence, whatnot, they could be court ordered to attend AA. So they have to do it, and they will check in with them to make sure that they are doing their meetings and things like that. Okay. If we are, again, treating for withdrawal, we want to make sure that they have taken their medications. We want to stay with them while they're taking their meds. Okay. We want to reassess the patient. If we've given something for anxiety, we want to reassess them and make sure that it is working. So, acute care meds. So, Librium is the drug of choice for alcohol withdrawal. Okay. Ativan and Xanax for anxiety. If they develop seizure, it's IV Ativan. It's 1 to 2 milligrams. It is super, super thick, so it's important to dilute that in at least 5 mLs of normal saline, okay, because it's very thick. It's just easier to push that way, okay? And you usually want to push it over at least a minute. Some people will push it right in, but ideally, at least a minute would probably be best, okay? Again, depending on the liver panel test, we do not want to give hepatotoxic meds such as Tylenol. We may not want to do aspirin either if the coagulation panel is off. Okay. If there's elevated, or we'll do the coag panel if the liver function test or the liver panel, you may hear it called, if it's elevated or if it's off. Remember, our clotting factors are synthesized in the liver, so we want to be mindful of that. If the coagulation is off, then we need to do soft toothbrush, no razor, which if they're going to be in BHU or inpatient, they may not be allowed to have it anyway. But if they would be, depending on the center that they are, we want to do electric razors instead. We want to minimize anything that can cause them to bleed. So we have to keep that in mind. Okay. Again, seizure precautions when they're withdrawing. Okay. And again, to look over acute intoxication again, we want to do IV fluids, kind of sleeping it off kind of thing, depending on the patient's situation. Treat headache with non-Tylenol or non-hepatotoxic medication. We want to monitor their lights if they're having excessive vomiting. Recovery position to help prevent aspiration. And then again, I want you to look up that CWA scale for alcohol withdrawal. So I hope this helped to give you a little refresher for Test 5. And if you have any questions, please let me know. I'm going to post this to our team site. I'll also put it in Brightspace. So email me with your questions, or you can post it in Teams. Thanks.